In this video, we shall learn about the GINA Guidelines 2019 for bronchial asthma, and this guideline has focused specifically on children more than 5 years of age and adults. So we being pediatricians will be focusing on the guidelines which are meant for children more than 5 years of age. What is GINA? GINA is the Global Initiative for Asthma, which was established to increase awareness about asthma among the health professionals, public health authorities, and the community. The 2019 GINA guidelines were devised to reduce the risk of severe asthma exacerbations and death. So, what are the major changes in the year 2019? In 2019, it has been stressed that no longer treatment should be given with short-acting beta agonists alone. Inhaled corticosteroids in low dose should be given either in patients are symptom driven, that is in mild asthma, or daily, and they should not be excluded, or the patient should not be managed with short-acting beta agonists alone, even if it is mild asthma. So, why? Because low-dose inhaled corticosteroids have been found to be very effective in preventing severe exacerbations and also exercise-induced bronchoconstriction even in mild asthmatic children. Early treatment with low-dose inhaled corticosteroids leads to better lung functions than if symptoms have been present for more than 2 to 4 years. So this is a very important point for noting for all the pediatricians, which they can introduce in their practice, and they will definitely see good results. So what are the criteria which have been used for diagnosing asthma as per the GINA 2019? There are two criteria. The first criteria is history of variable respiratory symptoms. The typical symptoms are one or more of the following, that is wheeze, shortness of breath, chest tightness and cough. They may vary with time and in intensity. Symptoms are worse at night or in early morning and are triggered or exacerbated by exercise, laughter, allergens, cold air or viral infections. That is why asthma flare-ups are very common in spring and winter season. The second criteria for diagnosing asthma is documenting a variation in lung function which is greater than in healthy people. This is criteria which is basically meant for confirming the diagnosis of asthma. Asthma, as we know, is a clinical diagnosis, but to confirm it, we need to get a pulmonary function test done and document it. If the forced expiratory volume in the first second increases by more than 12% of the predicted value after inhaling bronchodilator, then that is, it is known as bronchodilator reversibility. The second criterion is average daily diurnal peak expiratory flow rate variability of more than 13% in children, and if FEV1 increases by more than 12% of the predicted value after 4 weeks of anti-inflammatory therapy, for example, leukotriene receptor antagonist, etc. Remember, bronchodilator reversibility may be absent during severe asthma exacerbations or viral infections. Suppose a patient is already on controlled treatment, so how will you confirm the diagnosis in these patients? In that case, we have to consider other investigations if the above standard criteria have not been met, or, for example, if lung function is normal, repeat the reversibility testing when the patient is symptomatic or after withholding bronchodilator medications for at least 12 hours. However, if the patient is on ultra-long-acting bronchodilator, then we need to withhold medications for at least more than equivalent to 24 hours if we want to test for reversibility. If the patient has frequent symptoms, then we may consider a trial of step-up and controller treatment and repeat lung function tests after 3 months to check for bronchodilator reversibility. This shall also be a surrogate marker of the diagnosis. During initiation of asthma treatment, inhaled corticosteroid containing treatment should be initiated as soon as possible after the diagnosis of asthma has been made, and this is the crux of what GINA proposes in the management of asthma in the year 2019 for children who are more than 5 years of age and in adolescents and adults. If the initial asthma presentation is with severely uncontrolled asthma or with an acute exacerbation, a short course of oral corticosteroids may be given and regular controller therapy be started thereafter. The step 1 of treatment comprises of low-dose inhaled corticosteroids with short-acting beta agonists given along with them. Step 2, the treatment of choice is regular low-dose inhaled corticosteroids, or if not, then daily long leukotriene receptor antagonists or low-dose inhaled corticosteroids whenever SABA is taken. Whenever there is flare-up, the patient needs to take a short-acting beta agonist, then low-dose ICS should be given along with that. Step 3 comprises of taking medium-dose inhaled corticosteroids or low-dose inhaled corticosteroids and LABA, that is long-acting beta agonist combination. Step 4 is medium-dose inhaled corticosteroids or low-dose ICS LABA combination, or along with that you have to take an opinion from a pediatric pulmonologist. And step 5 is an advanced stage of bronchial asthma when you need to refer the patient for phenotypic investigation and consideration of add-on treatment, which you can give any one of the following. Actually, this treatment is still in pipeline, is not commonly used, and then you have to refer to a pediatric pulmonologist for consideration of starting treatment as these. For example, if there is a history of severe exacerbations, a tiotropium mist inhaler may be tried. If there is severe allergic asthma, then anti-immunoglobulin E drug, that is subcutaneous omalizumab, may be tried. Severe eosinophilic asthma, anti-interleukin 5, that is mepolizumab, may be tried. Anti-interleukin 5 receptor, that is benralizumab, and anti-interleukin 4 receptor, that is subcutaneous dupilumab, may be tried. But these are not to be given by the practicing pediatricians. They are to be advised only by an expert or a pediatric pulmonologist. Along with assessment of severity as per the GINA 2019 is done retrospectively from the level of treatment which is required to control the symptoms and the exacerbations. As per GINA 2019, mild asthma can be controlled is that which can be controlled with step 1 or 2 of treatment, and severe asthma is that which requires at least step 5 treatment. So intermediate shall be moderate asthma. On follow-up, we need to do 3 things: assess control, adjust treatment, and review response. For assessing asthma control, the level of asthma control over the past 4 weeks is to be ascertained. Also, the risk factors for poor asthma outcomes have to be seen. Along with this, one must rule out comorbidities in the form of rhinitis, rhinosinusitis, gastroesophageal reflux disorder, obesity, obstructive sleep apnea syndrome, depression, and anxiety. Assess and reassess the treatment issues, which are basically the inhaler technique, the drug side effects, adherence or compliance problems, and a written asthma action plan is generally preferable to be handed over to the patients suffering from bronchial asthma. So for assessing the level of asthma symptom control over the last 4 weeks, one has to ask the following 4 questions. Has the patient had any of these during the past 4 weeks? Daytime symptoms more than 2 times per week? Any night awakening due to asthma? Reliever medications requirement more than 2 times per week? Or any activity limitation due to asthma? If answer to the above 4 questions is yes to 3 to 4 of these questions, then it is an uncontrolled asthma. If 1 to 2 of these, then it is partly controlled asthma. And if answer is yes to none of these, then obviously the patient has a well-controlled asthma and the same therapy to be continued, or we may consider a step down of therapy, which we will see later. So the following are the risk factors which determine poor outcomes of asthma. First is having uncontrolled asthma is a big risk factor itself for a poor outcome in asthmatic patients. Second is potentially modifiable risk factors. Related to medications, for example, inhaled corticosteroids not prescribed in the beginning, poor compliance or adherence, incorrect inhaler technique, high use of SABA, comorbidities, coexistence like chronic rhinosinusitis, GERD, confirmed food allergy, anxiety and depression, exposure to smoke allergens or air pollution, major socioeconomic issues, and in lung function, if there is low FEV1, especially if less than 60% predicted, and other independent risk factors are ever being intubated or in ICU for asthma and having more than equal to one severe exacerbations in the last 12 months. The risk factors for developing a fixed airflow limitation which show very little response to bronchodilator therapy are prematurity, low birth weight and a greater infant weight gain, lack of inhaled corticosteroid treatment as always, exposure to tobacco smoke or noxious chemicals, low FEV1, chronic mucus hypersecretion, sputum or blood eosinophilia. Risk factors for medication side effects. For systemic side effects, the risk factors are frequent use of oral corticosteroids which are long-term, high dose and or potent. Also, taking P450 inhibitors. The local side effects are seen usually with high dose or potent inhaled corticosteroids and a poor inhaler technique. So, risk factors should be assessed at the time of diagnosis and then periodically at least every 1 to 2 years. FEV1 should be measured at the start of treatment, 3 to 6 months after starting treatment, and then periodically every 1 to 2 years, and more frequently in those with higher risk of flare-ups and or lung function decline. Review the response and adjust treatment 1 to 3 months after starting treatment and then every 3 to 12 months after that. However, after an exacerbation, a review visit needs to be done within a week itself to look for the response to medication. If you need to consider stepping up the treatment, that is move from a lower step to a higher step of treatment, step up can be done in two manners. First is a sustained step up, which is a sustained step up is at least for 2 to 3 months. If symptoms and or exacerbations persist despite 2 to 3 months of control or treatment, and a short-term step-up is for 1 to 2 weeks by clinician or patient during viral infection or allergen exposure. A step-down treatment is done once good asthma control, that is, answer to the 4 questions, is negative, having been achieved, and is being maintained for 4 months to find the for 3 months to find the lowest treatment that controls both symptoms and exacerbations and minimizes side effects. Inhaled corticosteroid dose is to be reduced by 25 to 50% at every 2 to 3 months. For example, if the patient is well controlled for 3 months, and if the patient is taking 2 puff 12 hourly of Buricot, then you can make it 1 puff in the morning and 2 puff in the evening after 3 months of this, and then continue for another 3 to 12 months, and thereafter reassess the patient and consider stepping down again if he is well controlled. An important thing which has come up in the GINA 2019 is the stress on inhaled corticosteroids. So do not completely stop inhaled corticosteroids in adults or adolescents with the diagnosis of asthma unless this is needed temporarily to confirm the diagnosis. So for assessing inhaler skills and adherence, the GINA 2019 mentions 4 C's. These 4 C's are: choose the most appropriate inhaler device for your patient, check the inhaler technique at every opportunity, correct the technique using a physical demonstration, and confirm you have a checklist for inhalers, whatever inhalers you prescribe. The non-pharmacological strategies and interventions meant for asthma prevention are avoidance of exposure to smoke, dust, or pollen, avoidance of foods which are known to cause allergies, encouragement of regular physical activity with advice about exercise-induced bronchoconstriction, and definitely avoidance of stress. If the patient is poorly controlled or is uncontrolled, then we need to follow the following steps. First, watch the inhaler technique using a device-specific checklist and discuss the factors for lack of adherence with the patient. Second, confirm the diagnosis of asthma. If pulmonary function testing is normal during the symptoms, you may reduce the dose of ICS by half and repeat PFT after 2 to 3 weeks. Remove the risk factors and manage the comorbidities as already been told earlier. Consider stepping up the treatment and referral to a pulmonologist or an asthma specialist if asthma remains uncontrolled after 3 to 6 months on step 4 of treatment, and not wait longer than that. So these are the salient things which have been mentioned in the GINA 2019 guidelines. These are quite different from that which has been mentioned in the latest textbook of Nelson textbook of pediatrics. And if any doubts, I shall come up with another video explaining the management, the diagnosis, investigations, and management of asthma in children less than 5 years of age, or in otherwise as per the Nelson textbook of pediatrics. And hope you are now clear about the GINA 2019 guidelines, because it is a very commonly asked question, especially from the post-graduates. So thanks for watching. Thank you very much.